Good morning, everybody. A lot of very interesting ceiling shots this morning. Just kidding. So we have we've had a couple of cases submitted, and we are also going to talk about diabetic gastroparesis. The most important piece of this discussion actually is the nutritional piece, and Carmela is homesick, but if our technology works properly, she'll still be able to present her piece of the presentation, and we should be able to get her PowerPoint up for everybody's review. But I'd like to do the couple of cases first, and then go from there, if that's okay. And while we're getting rolling, if anybody has any cases that they want to bring forward this morning, think about it now, and we'll move back to them. So both cases that were submitted came from Center for Complex Care at Community Health Alliance. Taylor Ann's got a couple for us, and let's dive right into those. I'm going to just, I think, describe them quickly, but I'm going to ask you to flesh them out for us. Taylor Ann, okay, the first patient is a 63-year-old gent who was started on thyroid, 0.5 grains daily, despite normal thyroid labs, and the question is, what am I missing? So a 63-year-old who complains of fatigue. He's got a history of depression and anxiety on an SSRI, an occasional Xanax, occasional benzodiazepine, and was started by another physician on half a grain of thyroid. So combination T4 and T3 therapy. And for the week that he's been on it, he's tolerated it well, and he requested essentially a second opinion on whether this made sense or not. Reportedly, his exam was normal, and the labs, Taylor Ann, that you sent are pre-treatment, TSH of 3.68, T4 6.6, and a T3 of 100, is that right?
Yes, that's right.
So those are before treatment?
That's correct, yes.
Okay. All righty. So just in terms, remember TSH, normal presumably is up to around 4.5 or 5 in the lab where these were done. The T4 of 6.6, as you'll know, that's not a free T4, that's a total T4. And it's kind of towards the lower end of the normal range, but in the normal range. And the T3, again, normal, and we've talked about measurement of T3 as being not part of our high-value care process because it really is not indicative of the normal functioning of the pituitary thyroid axis. When we look at a total T4, it's important to get a sense as to whether this is actually reflecting the free hormone value, right? Because really it's the free hormone that we're interested in, so measurement of free T4 is far more helpful. A low normal total T4 is probably normal, but could conceivably be, towards low end of normal. We have no way of assessing the free hormone level without even measuring free T4 or measuring the binding protein, TBG, in some fashion. So total T4 is not helpful. TSH clearly within the normal range. And the issue is fatigue enough of a reason to start a patient on a medication when you don't have biochemical proof of an illness or an abnormality? And my gut feeling is we should probably try to avoid doing that because we don't know what the end point is, right? Are we going to commit this 63-year-old to lifetime thyroid hormone therapy when we've not really proven that he's got anything wrong with him? So I don't know, is that kind of,
That was
does
my
that fit in your,
my gut feeling, but I reassured the patient that I would ask the endocrinologist because sometimes they don't find our opinions valuable. So yeah, that was my gut feeling too, and that all of his labs are normal. So why would you treat somebody with normal labs?
yeah, so I think we're on the same page.
Yeah, especially in the presence of depression and anxiety, because we see so much fatigue with depression and anxiety. So why would we blame it on something else?
Absolutely.
Okay, thank
So
you.
here's what I would do though, just so you and he can really feel comfortable, I might measure his free T4 level just to ensure that it's clearly normal. And maybe repeat the TSH and maybe thyroid antibodies if you really want to hunt for an etiology.
Okay.
But again, I think that's a bit of an overreach because we have no real basis to think there's anything wrong at all. So just for certainty, I get a free T4 and a TSH. If they're both normal, I would quit at that point.
Yeah, it was interesting because his previous physician, and he just came to me for a second opinion, but the previous physician convinced him that these normals were on the low end, which
Yeah.
what I try to tell patients is when you're in the normal, you're in the normal. And even if you are a little bit out of those normal ranges, it still might be normal for you. So I'm going to try to convince the patient otherwise that they are normal and that maybe they should reconsider taking this thyroid medication. And on that note, what is the value of treating somebody with this thyroid medication, these grains? Do you treat people with that?
So again, the standard of care for patients with hypothyroidism is treatment with levothyroxine.
Right.
And the reasons for that are, A, we've been doing it that way for a long, long time. It's very easy to monitor because we can follow free T4 levels and we can follow TSH into the normal range.
Okay.
That's how we do it. When we treat patients with levothyroxine and normalize their values, and they still kind of feel not so right, usually it's because the not so right piece is unrelated to the thyroid. Okay. But we occasionally will use combination therapy. Remember, when you give thyroid hormone, this is desiccated thyroid hormone, and whether you call it armor thyroid or nature thyroid, it's a combination of T4 and T3, and it's ground up animal source thyroid hormone. The problems if we ground up human thyroids, it would probably be okay to use that sort of a preparation. But animal thyroid is a little bit abnormal for humans. Tends to be a little heavy in the T3 component, a little light in the T4 component, and monitoring therapy becomes challenging. Remember, the T3 component is very short-lived, so it's absorbed rapidly, disappears rapidly, and TSH levels tend to fluctuate a little bit in those patients. So finding the sweet spot with that medication can be a bit more challenging. Using T4 alone is much more predictable, much more easily managed, and should be, and again, is the standard of care, and I think that's where we should leave that. I see no upside to initiating therapy with this kind of a medication. You might, at the back end, come to it because patient hasn't done well with standard therapy, but I wouldn't start that way. Okay, great. Thank you so much.
I have a question on that note.
You bet.
Would you consider DCing the thyroid medication prior to repeating labs, or it doesn't matter?
Oh, absolutely. Yeah, good point. I think that, again, you want to assess this patient in his native state. And I would think you want him off meds for 4 to 6 weeks. Just because, again, you want to really have numbers that you can count on. So that's a great point. Thanks.
Yeah. Thank you.
Now, listen, if he refuses, is there harm done? Only in terms of the long-term cost of therapy. And I would bet you that sooner or later he abandoned therapy anyway.
Okay.
Okay.
Thank you so much.
The other patient is a bit more challenging. And again, I'll give you a quick synopsis of what Taylor Ann submitted. This is a 43-year-old woman who was found to have an isolated low sex hormone binding globulin concentration. What we know about her is she was being evaluated for polycystic ovarian syndrome. All of her testing was normal, except SHBG was 23 with a normal somewhere around, lower limit of normal around 30, I think. And she's hirsute, and she is obese with a BMI of about 40. She's normotensive, and the lab data that we have looks like the following. Her total testosterone was well in the normal range, actually kind of towards the lower end. SHBG was 23 with a normal of 30. Her free testo was 3.1. And we measured estrogen levels, which are highish. Nothing to write home about, I don't think. And she's got TPO antibodies that are present in pretty high titer. So a couple of questions. Oh, and her urine-free cortisol is normal as well. So let me ask you this question, Taylor. And why do you do these tests?
So the patient is, she's convinced that her fatigue, she has facial hair, that she has PCOS. And so based on what I researched, these were the tests to run. And so basically she keeps coming in the office. She's a frequent flyer of mine. So I kind of was ruling out anything I could for her. And then of course, everything's negative except this sex hormone binding globulin. So of course she's convinced now that there's something wrong with her.
Okay.
And I cannot explain to her, because I do not have the knowledge base, that there is nothing wrong with you without having a little bit of backup. So that's why it was just basically what do I do with this number,
right? Now that you got it, now you're stuck with it, right? Now you break it, you own it. Is that the so here's the way I would look at this patient. You know, PCOS, of course, is really a clinical diagnosis, right? So it's based on clinical evidence of hyperandrogenism, menstrual irregularity, and pretty much it. And ovarian ultrasonography showing cysts is fine, but doesn't really make the diagnosis for you. So it's really a very clinical diagnosis. Now, does she have menstrual irregularity?
She does have very heavy periods, but one thing that mentioned is that she never had any problems getting pregnant. I think she has 6 children.
Okay.
So, and she does have a history of, like I said, I think she's 43. She's been worked up by a lot of people, and she did report having some cysts on her ovaries in her 20s. It's not something I told her there's no reason for me to get an ultrasound on her at this point. So I didn't, but she does report having the cyst on her ovaries, and she does have that appearance of a PCOS patient.
Okay.
If you were to look at her, you would be like, yeah, I could see that being close with hers, but.
So the way I would look at this as the following. You know, PCOS tends to present relatively early on. You know, it's kind of slowly progressive through puberty into the early 20s, without, you know, any evidence of infertility or irregular menses. Heavy menses I would not categorize as part of that, but irregular menses, I'm not really feeling it.
Okay.
What you want to be sure about is that in these patients, nothing much has changed. In other words, if she were to come in and say, you know, she was always thin and not hairy, and within the past 6 to 12 months, she's had an eruption of facial or body hair, my antenna would be raised. In other words, I'd say, oh, something has changed in this patient that makes me uncomfortable. So that would lead me to think, God, could she have an androgen-producing thing? But PCOS tends to just kind of slowly evolve over time. Women, as they get older, tend to develop more hair, especially facial hair. If she were to develop hair growth in abnormal places, I would be very concerned, right? So the places where I would worry about new hair growth would be pectoral region, upper back, upper abdomen. Those would be clearly pathologic findings, but some facial hair growth is not terribly worrisome. Look at it this way. What happens to men as they get older, right? So men have a lot of androgens. Most men have a lot of androgens. And hair develops in certain body places at specific times in life, right? So, for example, ear hairs, I find, don't show up until you're in your 60s. And then, so I'm saying, well, that's interesting. So why should that be, right? Androgen levels, if anything, are tapering down a little bit at that level. So it's got to do with duration of exposure, right? So we've got 60 years of these androgen receptors being exposed to testosterone, and they finally are capable of sprouting some hairs. So in women, again, it's duration of, or duration of exposure. That's why women, as they get older, tend to develop more hair growth. The kicker here is obesity, all right? And low SHBG, low sex hormone binding globulin, is a feature of obesity. And I think that's probably what we're dealing with here. Now, it's interesting because SHBG does have meaning. There is, and it's inversely related to risk of metabolic syndrome and probably to coronary disease. So it may just be a marker for metabolic abnormalities, but it is clearly an obesity-related finding, and it's a pretty linear thing. As obesity progresses, sex hormone binding globulins tend to decline. So I think that's what we're dealing with here. I don't think there's anything else amiss.
Okay.
Okay.
So what would I need to be concerned about if I did see a low SHBG? Is there any other numbers that I need to be looking at to raise any red flags in the future?
Well, so the only thing I would look at in a patient like this would be, coronary risk factors. So I would kind of I would treat her as the way you would any other obese person and say, all right, does she have prediabetes? Does she have dyslipidemia? Those would be the things I'd be concerned about. Did she have gestational diabetes in any of those pregnancies?
No, yeah, she
Okay.
not. And none of this is linked to her thyroid either, right? And I have her on a pretty hefty dose of some levothyroxine. She's had Hashimoto's after her first or second kid.
Yeah. No, I think you've got a clear diagnosis of Hashimoto's. Presumably you've driven her TSH down to a nice low normal level. The SHBG is, I think, conforms to her body weight. Okay. And I'd probably quit there. So the only thing I would add is that when you assess androgen status in a patient, measurements of free testo are pretty unreliable. I'm a particular fan of measuring total testo and SHBG. Okay? And I think that's sufficient. I think once we start ordering more tests, we just have more explaining to do. So I like, and remembering that you're kind of trying to paint a picture here rather than thinking that there's a hard and fast line that separates normal from abnormal. So when I look at testo and SHBG, I get a sense, is the total testo kind of high-ish and the SHBG kind of low-ish? And then I'm thinking, well, then there's probably more free testo available. When I measure free testo, I'm never sure that I can really trust those results, so I don't get so I'm not hung up. So my preference is total testo, SHBG, and get a sense as to where you stand. Remembering, the lower the SHBG, the higher the testo, the more free hormone is in there.
So what would you do with that patient if you did see an increased level of total testosterone with a low SHBG?
Again, I wouldn't necessarily do anything, right? If she's having regular cycles,
Okay.
And she got a little hirsutism, then I would just have her do whatever felt right to her in terms of eliminating the hair.
Okay.
Okay. Now, obviously, her ethnicity plays a role in this. I don't, certain populations tend more towards facial hair growth than others. But the thought that removing facial hair makes it come back more aggressively is not true. And there's plenty of evidence to support that. So whether it's shaving, plucking, waxing, any sort of depilatory will not make the situation worse.
Okay, and do you start patients on spironolactone? Do you find that helpful, or?
I use spironolactone a lot.
Okay.
I think it's very helpful, but again, in the absence of I don't think you have a diagnosis here. I don't think you've got a diagnosis of PCOS.
That's what I told her, and she's like, "Are you sure? Are you sure?" And I wasn't going to refer to you guys for you to tell me she doesn't.
Yeah, would there be any? She's borderline hypertensive. You could make a case for. There would be no harm in putting her on some spironolactone. You have to use enough of it to be effective, though, and enough means somewhere between 50 and 100 milligrams BID.
Okay. Oh, BID.
BID.
Okay. Perfect. Thank you so much.
You bet. Anybody else want to chime in? Anybody with a similar clinical scenario that they've been presented with, or challenges in managing this sort of an issue?
Would she use metformin for her? Anything else?
Interesting thought. If she had prediabetes, I might jump in with metformin thinking that it could accomplish a couple of things, right? One is probably improving her glycemic control. It might help her with weight management and could potentially be useful. But again, if she didn't meet our criteria for prediabetes, I would not. And obviously, you've addressed the issue of diet and exercise with her. So, okay. Anybody else with a patient they want to talk about or a challenge? Otherwise, we can talk about diabetic gastroparesis. Okay.
Hold on.
Krista, was that a hand up or camera adjustment?
Well, this is Wells.
Oh.
Hi, this is Mike from Wells. I've got a quick question just based on some stuff coming up in the news lately. There's a lot of concern about pancreatic cancer, and it seems to be that in the media lately, it's tied a lot to new onset, diagnosing somebody with new onset diabetes. I get the feeling we're going to have a lot of these patients coming in. What are your thoughts on, discussing this with patients that have diabetes and that they're reading in the news a lot about pancreatic cancer?
Okay, I'm going to answer that question without knowing about the specific news reports that you've seen, but pancreatic cancer is a pretty unusual disease. Typically, we find it after the horse is out of the barn, so to speak, As a cause for new onset diabetes, it's quite rare. So in the group of patients who present to you with new diabetes, almost all of them are going to have type 2 diabetes, obviously, and pancreatic cancer would not be a cause there typically. There are certain scenarios in which I get concerned, and that would be in a patient who has no family history, whose onset of diabetes seems to be fairly precipitous, and who's had weight loss or back pain or other major constitutional issues. But again, I don't think that I would start imaging the pancreas in every patient with newly discovered diabetes. Any other thoughts?
Well, coming from MD Anderson,
That's what we're everybody at. Right.
the School of thought was that metformin actually had some preventative effects in the area of pancreatic cancer. So I haven't seen the new stuff about pancreatic cancer and new onset diabetes. So if you've got a reference for it, I'd like to take a look at it. But the thought there was starting people on metformin could have some preventative effects as opposed to metformin or new diabetes causing pancreatic cancer. So.
Jumping back to the previous patient with the spironolactone, it was, gosh, it might even be 2 years ago now, Dr. Klass, that we talked about a patient with PCOS, and we started her on spironolactone, but I can't remember what we were trying to do with that. I remember it had something to do with aldosterone, but would you just cover that real quick again?
Sure. Spironolactone is an anti-androgen, which we discovered sort of by accident. You know, we have used it for as a potassium-sparing diuretic in our hypertensive patients, and seemed like a great thing until our male patients started developing gynecomastia, and you know, somebody got the bright idea that maybe this drug was blocking androgen action. And it turns out to be a very potent anti-androgen when it's used in a significant dosage, you know, not at 25 BID, but at bigger doses, it blocks the action of testo at the androgen receptor. So in women with hirsutism, it tends to protect the hair follicles from androgen excess. And remember, when we talk about hair follicles, think about this in a somewhat broader sense, right? The term I like to use is the pilosebaceous unit. So it's both sebaceous glands and hair, so that acne and hair are the same thing in my book, right? It's activation of that unit, which produces sebum and hair. So for women, young women with PCOS, where acne is an issue, spironolactone can be very effective as well.
Would you use it on young men, or would you tend to stray away from gynecomastia?
No, it's a problem in men.
Okay. And then the next question that, you know, I'm going to get from a woman is, am I going to lose the hair on top of my head like men do? And should I be concerned about that at high doses of spironolactone?
No, just the converse, right? If you, again, it can protect from women who are developing male pattern baldness. You know, theoretically, we don't typically do this because the process tends to be so slow that we're not intervening. But in theory, it would protect those hair follicles from androgen action as well.
Perfect. That makes sense. Okay, thank you.
You bet. Okay. All right, so diabetic gastroparesis, then this is going to work for me, right? So this is a challenging issue. Not very common, but probably a little bit more common than we tend to think about it. So the point that I want to make, first of all, is we're going to talk about the stomach, but remember that diabetic neuropathy can affect any part of the bowel, but discussion of diarrhea and constipation related to diabetic bowel dysfunction, I think, is a topic for a second talk. So I wanted to stick to the stomach for this talk. Remember that GI complaints are enormously common, right? So that if you take the folks who walk into your office, somewhere between 10 and 20% are going to have some functional GI complaint, bloating, gassiness, intermittent nausea, etc. So just in the general population, there's a lot of complaining about GI distress, and the fact is that makes it a little hard to know whether or how prevalent GI distress, separate and above the background noise, is related to diabetes. But in a very carefully done population study, it seemed pretty clear that people with both type 1 and type 2 diabetes have more GI symptomatology than the non-diabetic population. And there's a clear correlation of degree of symptomatology with degree of glycemic control. So bad glycemic control begets more GI symptomatology. And patients with type 1 diabetes, are more likely to have diabetic gastroparesis than are patients with type 2. You know, the fact is that type 1 patients, when they develop microvascular complications, tend to have a more aggressive clinical course than do patients with type 2 in general, and that applies here as well. And in my practice experience, the patients with type 1 diabetes with gastroparesis were devastated by this problem. Patients with type 2 diabetes and disturbed gastric function were moderately annoyed, but the type 1 patients were absolutely devastated, and it was devastating for me because managing them was so difficult. The other thing to remember is that our typical GI function testing is not all that great. I think we have false positives and false negatives with gastric emptying studies. And to a great degree, if they support our initial feelings about this patient, that's great, but they don't always, and in general, we need to make diagnoses and treat patients oftentimes on clinical grounds alone. So, diabetic gastroparesis is a manifestation of autonomic dysfunction. It often comes with other evidence of autonomic dysfunction. So patients can have orthostatic hypotension. They can have abnormal sweating. And the term that is used sometimes is gustatory sweating. Does that sound familiar to anybody? So gustatory sweating is the sweating that happens when you eat. So you'll eat something and people start sweating. It's an abnormal autonomic effect of gastric distension. Autonomic neuropathy tends to be a late complication, right? So we almost never see autonomic neuropathy, whether it's gastroparesis or orthostasis, in the absence of other evidence of diabetic microangiopathy. And in fact, if a patient has no other evidence of diabetic complications, I would be very hesitant to think that they could have diabetic gastroparesis. So what other things might you see? Well, they might have some evidence of retinopathy. Even if it's just microaneurysms, which you can detect in your office visit, that would lead me to think that this is possibly connected. If they have peripheral neuropathy, I'm more apt to believe that autonomic dysfunction is present. But if they had none of those things, I'm thinking there's something else going on, okay? All right, and just like other neuropathies, this has to do with loss of neuronal mass, right? So this is a fallout of nerve endings, and just like a skeletal muscle that loses function after a stroke, right? It's because of denervation of those muscles, right? And in gastroparesis, we're talking about muscular dysfunction, right? The stomach is not contracting normally, and it's because you've lost vagal mass, right? So it's not a muscle thing, it's loss of nerve function. The muscle becomes denervated and dysfunctional. So what are the typical symptoms, if there are any? Early satiety, right? So the stomach doesn't empty. People get filled more quickly. Sometimes they feel full for a long time after a meal because, again, stomach is not empty. They're bloated. They're nauseated. And if they're vomiting, they often vomit, chewed food. So they've chewed and it's been lingering in the stomach and it comes back. Abdominal pain, not terribly typical in patients with gastroparesis. You got to differentiate pain from bloating, right? So patients bloating may say, well, it's painful, but it's a different thing. Patients with abdominal pain, it's much less common in diabetic gastroparesis. Physical examination, not terribly helpful. Does anybody remember the succussion splash from physical diagnosis? even a single hand? Am I that much older than everybody else? Okay. So try this on your friends. A succussion splash is basically the result of an enlarged, filled stomach. And when you jiggle the body, you can actually feel splashing up in the left upper quadrant. All right? This is probably not the way you're going to make the diagnosis, but it is a cute little thing that you can impress your friends with. So here's the thing. Like other diagnoses that are not glaring on the surface, you have to remember to think of it. And when do you need to start thinking about it? Well, I thought to start to think about it when I'm struggling with a patient who's pretty compliant, who's actually taking their meds, and whose blood sugars are all over the map, where they're having unexplained highs, unexplained lows, and oftentimes severe lows. And it's because their food absorption is totally unpredictable. Sometimes it's hanging up in the stomach, sometimes it's dropping right through. The composition of the meal is going to determine how quickly the stomach empties and when that food bolus is going to be presented to the gut for absorption. So what happens is the timing of treatment and presentation of that meal bolus to the gut become disordered, right? So sometimes the insulin gets there first and the patient gets hypoglycemic. Sometimes the food gets there first and blood sugars are high. So this is one of those causes of unexplained poor glycemic control. Now the A1C may be fine because they kind of average out, but where they're having peaks and troughs and bottoming out and crashing, this is something to think about. If you think about it, you want to be sure that they don't have some other problem, right? So in the patient who's got no other evidence of diabetic microvascular complications, think about other diagnoses as well. Sometimes the patient needs an upper endoscopy just to make sure they don't have an obstruction, right? So early satiety, delayed gastric emptying could be a manifestation of a gastric mass or a scarred pylorus. So sometimes upper endoscopy is necessary. If that's normal, then doing a formal gastric emptying study is worth doing, all right? It's an easy, inexpensive test, and all that's done is we mix up a little technetium with eggs, delicious in an omelet, and we measure how rapidly that technetium disappears from the stomach. And there are normal values for how quickly the technetium should disappear out of the stomach. And if it lingers in the stomach for a longer period of time, that suggests that there's a delay in gastric emptying and a function of bad gastric contraction. Sometimes the results are indeterminate or don't support what you've been thinking. A capsule enteroscopy can be done. Right? So you can take that capsule, swallow it, and see how long it stays in the stomach. Right? Another relatively easy but somewhat more expensive test to do. And finally, proof positive can be determined by measuring the electrical activity of the stomach. And obviously this is only done in fairly sophisticated centers that have the capacity to do gastric electrical activity studies. So the treatment is challenging because a denervated stomach is hard to control. Right? Remember, it's denervated because we've lost the nerve and we can't make the nerve grow back. So we need to work around that. Obviously, the goal here is to prevent this from happening. And the better we control diabetes, the much smaller the probability of seeing patients like this. Again, the devastated patients who I've seen have had long-standing type 1 diabetes, often during their teenage years when their control was horrible. And this is just a very late manifestation. It's a problem. In general, insulin is going to be a better choice because we have a little bit more control over when it acts than we do with oral agents. So oral agents, even in our patients with type 2 diabetes, are going to be potentially problematic. And in a patient where we've made this diagnosis, eliminating oral agents is probably advantageous. With insulin, therapy should be basal bolus, right? Because we're going to want to try to synchronize our meal insulin with when food is getting through into the palate. Now, we can do it with pump or we can do it with injections, but we shouldn't be using pre-mixed insulins in these patients because we just can't control the peaks of insulin therapy. Boluses often should be administered after meals. Again, after we know the food has gotten to the gut, then it's safe to give our prandial insulin. If we give the bolus before the meal, we may run into problems with insulin hitting before the food arrives, right? So the risk of hypoglycemia becomes greater. Some people like to use regular insulin because of its slower onset of action, so it may actually time out better with delayed gastric emptying, but not my preference. I still think that using newer insulins, but administering our mealtime insulin postprandially is our best bet. But the most important part of treating patients is diet. And I'm going to turn it over to Carmela to talk about that.
Okay, so I'm going to share my screen.
Oh, you sound terrible.
Not the best. That's okay. Can you guys see my screen okay?
Yep, you're good.
Okay. All right. So as Dr. Klass already indicated, tight glycemic control is absolutely imperative with helping patients with gastroparesis. We know elevated blood sugars can also slow the rate of the gastric emptying. So that's one big consideration and probably one of the first things that we want to help our patients with. We're going to talk today about the helpfulness of small meals that are frequent. Generally speaking, our stomachs empty every 4 hours. So for someone who has delayed gastric emptying, they could go 6, 7+ hours, especially on a larger meal. So doing small, frequent meals can help, ones that are low fat, low fiber. And there's even some consideration that we have them blend their meals in a blender or sticking to liquid meals, which I'll talk a little bit more about in just a minute. But those may be a bit more tolerated than doing more solid meals. In severe cases, we may consider enteral nutrition and doing some J-tube feedings. And of course, that would be something we would want to hold out for someone who's significantly malnourished, inability to maintain a healthy weight, or significant weight loss, that oral nutrition wouldn't be sufficient to bring their weight back up to a healthy level. Dr. Klass already mentioned, but yes, there's significant consideration for taking their insulin after eating versus before. And we do find that walking, so doing like moderate exercise, just moving around after eating can actually help with the gastric emptying. I tell people no intense forms of exercise, which could actually decrease blood flow to the stomach, which we don't want to have happen. We want more like moderate exercise, just moving around after eating, maybe even for 10 minutes, can maybe help things move through a little bit more quickly and help with their comfort. Unfortunately, we don't have any controlled trials of different food modifications, liquid, solid, low fat, high fat, for treating gastroparesis. So a lot of what our recommendations are coming from is our professional judgment and our clinical practice. And I say this mainly because I find for a lot of patients that I work with who do have gastroparesis, one person can tolerate, a quarter of an avocado or half of an avocado, and that sits really well for them. It's smooth, they don't have to chew as much, and it's something that goes down really easily. But for somebody else, with it being a high fat food, even if it's healthy fat, someone else may not tolerate that as well. So there is some preferences or just personal trials and errors, I think, with some people of what foods help them and what foods can they not tolerate. I have one patient who loved apples, and there's just no way that she could eat the skin on it. She couldn't chew it well enough. It wasn't tolerated well, so when she wanted an apple, she had to peel the skin. So sometimes it's just working with the patients and helping them kind of write down foods that they find that they're not tolerating and foods that they do tolerate, and not always sticking with just within these specific lines of low fat or low fiber, because everyone can maybe be a little different. So specifically speaking about common food modifications that we do find helpful, as I mentioned, is small frequent meals, some that have a little bit of healthy carbohydrates. So we have to have a balance around not too high fiber, but maybe just a couple of grams of fiber if they can tolerate it. Some lean protein that's not too high in fat. And then trying to kind of limit how much liquids that they're drinking along with that meal, and that they're chewing really well. They may have to chew 20, 30 times before they swallow to kind of improve some of that digestion before it heads on down. There's, of course, some concerns of early satiety and bloating, which then causes a lot of people to stop eating throughout the day. They may start with one meal in the morning, some eggs and some toast, and that just has a hard time sitting with them, and then they won't eat until dinner time. And there increases the risk of hypoglycemia. If they're on insulin, it could increase the risk of them just getting adequate nutrition in. And so we want to work with them specifically on doing those smaller meals, maybe even breaking breakfast into 2 small meals if they can't tolerate a certain amount, and helping them to have more of a steady consumption of carbohydrates throughout the day with some lean proteins that help them to stabilize their blood sugars. A lot of patients also find that solid meals are more tolerated in the morning than in the evening time. So we may have to switch them to, like, starting around that, afternoon snack or evening meal is to doing more liquids, whether that's protein shakes or that they're actually blending up their meal that the family is having in the blender, so that the body doesn't really need to digest much of it, and it's all pretty much done prior to even drinking it. So liquid meals can actually be helpful later in the day. As I mentioned, chewing food, sitting up during the meal, and at least 1 to 2 hours after they eat. So really discouraging people to lay down after eating. Reduced fat diet. Fat can inhibit gastric emptying. When it's in a solid meal, we don't necessarily find that to be the case in liquid form. So if they, want certain types of foods and they are open to blending it, maybe that's where we can add in some of their fat. I honestly discourage the use of consumption of like oranges, broccoli, cauliflower, certainly cabbage, Brussels sprouts. Those are really difficult for a lot of patients who have gastroparesis to digest and to tolerate. And there is an increased risk if they don't chew well, or if they have a severe case of gastroparesis, that they could get a blockage from some of that undigested food. So unfortunately, we have to be somewhat careful with helping them with getting fiber, but a lot of times they need to stick to like under 15 grams of fiber a day. This I put up here, not that these are the only foods that people who have gastroparesis can consume, but these are often very tolerated by patients. And the intention is to making sure that they have a healthy amount of carbohydrates, but also not excessive. And for some patients who can tolerate milk or protein shakes, they may kind of go overboard a little bit with how much that they're drinking, or they're only sticking with that and not doing any solid meals. So it's something, I think, just to encourage them to try different foods, see how they tolerate it, and to use some of these more liquid or smooth consistency foods for times that they're having a bad day and they're not really tolerating much, or again, later on in the day when solid foods tend to not be so tolerated. Unfortunately, some of the things that we can see with patients who have gastroparesis and might really encourage the use of a nutrition referral is inadequate vitamin or mineral intake, of course, impaired nutrient utilization because of lack of digesting, excessive fiber intake than their body can handle, of course, altered GI function, and one risk very much is unintended weight loss. And as I mentioned, that's oftentimes in more severe cases of gastroparesis, but it's a consideration I think we have to make in asking them how their weight's been going and how they've been eating in some of those severe cases. We also need to just monitor how they're eating so that if we need to look at magnesium for supplementation, iron and ferritin, vitamin B12 or vitamin D. As Dr. Klass mentioned, more liquid forms would be better tolerated. The last thing I added on here, just for some help, I think, is when would we consider someone who might need enteral nutrition support? Parenteral nutrition we would want to really keep as our last option, but for enteral nutrition is someone who's had significant unintentional weight loss. Again, in severe cases, but it's a risk. So if someone has a BMI of 18.5, or less, or their BMI is 18.5 to 20, and they've had about 5 to 10% weight loss within 6 months, we really need to keep a close eye on them. We really need to evaluate what they're eating and what changes might we need to make to help them to get inadequate nutrition, or we need to consider alternative sources. And then you see there the medium risk, less weight loss, and a little bit of a higher BMI. And the last thing is just to help taking the low fat, low fiber, small frequent meals throughout the day, moderate amount of carbohydrates that we evenly spread out to help with stabilizing blood sugar controls, is just a menu here. So that is just for you to help, and we do have handouts and we're happy to post them on the website if that's something that you would like, that it has something like this so that you can hand them out to patients if you ever find that needed.
Okay, thank you. And we'll put those up on the website. So I think we're going to swap back to my PowerPoint. And I've also been told that we've got to abandon ship precisely 9. So let's see. Should come. Okay.
Right there.
Perfect. Okay. So I wanted to talk to you. Can we get to presentation mode? I guess I can. Okay. Great. So I wanted to talk a little bit about therapies other than diet briefly, because I don't think that there is much indication for them. These are meds that all have a mixed profile. So in terms of things that make the stomach contract better, our options are fairly limited. The best drug we ever had was cisapride, which was removed by the FDA many years ago. It was actually a very good prokinetic agent, but caused cardiac irregularities and sudden death. So weighing risks and benefits, the decision to remove that drug was made. Metoclopramide or Reglan is a drug that gets used a lot, but I just want to make the case that this is a problematic drug and should not be initiated lightly. Does it have good prokinetic effects? Yes. It does promote gastric emptying, but for chronic use and at high dose, the risks of extrapyramidal side effects are quite substantial. And if anyone has ever seen a patient who's developed akathisia, it's a terrifying adverse effect, and don't initiate this therapy lightly. We can use it occasionally if symptoms are severe, but remember that it's a double-edged sword. Erythromycin, obviously a safer drug, but a less potent drug. But erythromycin and other similar meds activate the stomach by binding to the motilin receptors within the stomach and can increase gastric contraction. So it can be effective at times. And again, our options are not that great. So it is a drug that we do use from time to time. But it's a drug that has to be given 4 times a day, which makes it challenging. Domperidone is a pretty good pro-motility agent, but it's never been approved by the FDA in this country for reasons that I frankly can't explain to you. It is available in Canada, and we have obtained it through Canadian pharmacies. It can be done that way, or it can be obtained through the FDA by making an application for it using the IND process, which is investigational new drug, and where there's a specific need, if this is going to be long-term therapy, going through the FDA route can be done. Nausea can be managed using our conventional anti-nausea meds. And when patients present with severe nausea and vomiting, they're oftentimes very agitated, very restless, and the addition of an anxiolytic can really be quite beneficial. So we've often done this in the emergency department, especially in our patients with severe type 1 diabetes whose glycemic control is problematic. They oftentimes will come in a kind of agitated state because they've been through this sort of episode before, and they know how difficult and miserable it is, and it kind of builds, it feeds on itself. And you sometimes need to break that cycle with a short-acting benzodiazepine. If our medical therapy and nutritional therapy doesn't work, so these are patients who have intractable gastroparesis with unpredictable gastric emptying, gastric pacing can be done, and our good friends at Medtronic are happy to provide a Medtronic gastric stimulator as well as an insulin pump for our patients. I've got one patient who's got a Medtronic epidural morphine pump, a gastric stimulator from Medtronic, and an insulin pump from Medtronic. She's got the trifecta, you know. She's one of a kind. Using Botox injected intragastrically has been tried, and it has demonstrated some efficacy. And finally, pyloric dilation using mechanical dilators has been performed just to allow food to pass straight through without getting hung up at the pylorus. So again, another consideration for patients with advanced intractable symptomatology. And I think I'm going to stop there. Big problem, not common, thank goodness, but when it's present, it can really be very challenging to manage.
Dr. Klaas, I have a question if you have a minute.
You bet.
For erythromycin, what kind of a duration would you be talking? Because we had a patient once at Renown that was on it for 3 weeks and everybody was worried about inducing resistance. So what would you have to say about that?
You know, again, it's a double-edged sword. When your options for therapy for this condition are so limited, I think you just have to accept that it's not perfect, but it is your best option. So I do think that, you know, we have patients who are on therapy for the long term. And again, resistance is clearly an issue. We're so sensitized to it at this point. It's a mixed thing. Fortunately, it doesn't come up all that often. All right, I hate to do this, but I think we've got to close out now so that somebody else can use our room.
Thank you.
Thank you.
Thank you. It was very good. Helpful.
See you all in a couple weeks.
Thank you.
Okay, bye.